Well, we're going to go ahead and get things started here. Tonight's
Locust. It's Locust, by the way. I just remembered.
Locust. Thank
Yeah,
you. God
you're
dang,
welcome.
Locust after me out there. Had to come in. So tonight's webinar, Mastering Advanced Intraosseous Delivery of Local Anesthetic in Pediatric Dentistry, but Josh and I have put a twist on it. This is actually a mashup. So this is going to be a little bit of beginner stuff and a little bit of advanced stuff. So if you feel like it's starting to drag and you know something, just hang in there because 2 slides later it's going to ramp up. And if you feel like it's too much ahead of you, it's going to slow down at certain parts as well. For those of you who don't know me, my name's Ann Bynum. I went to Florida State. I went to Iowa. I did peds at San Antonio. And I've been practicing for almost 30 years now, actually. I'm going to my 30th dental class reunion in Iowa in a couple weeks. So I'm getting my liver ready for that trip coming up. And the real reason that I'm available to do webinars like this is that I have literally made every mistake in the book when it comes to practice management and running a practice and having a team and just doing everything. And I always try to be involved in things that put my colleagues on a shorter learning curve. And I've always been an early adopter. And that's why I was so interested in these devices in 2023 when they came out. And I'm just super happy to be here tonight to share what Josh and I have learned and to just, promote NuSmile and their products that they get into the hands of ourselves and our colleagues to make us better at what we do for kids. I practice with my husband. He's a general dentist. He's a super dentist, does all kind of all on X and cosmetic stuff. And I'd rather sit and fire ants. This is our family. We got 3 good looking boys. I got 3 good looking women. The one in the middle is going to replace his father one day. That is the plan there. He's just started his 3rd year of dental school. And fun fact, he's on break right now between summer and fall semester. And he's got 2 of his classmates shadowing me this week. And he sat in the chair and he let his classmates use the sew-in on him. He did all 4 quadrants of his mouth. So super, he just said, I don't mind doing it because it doesn't hurt. He said it's much better than stab lab in dental school. And this is my other family. This is my work family. We're crazy, crazy, crazy. We're 5 doctors strong and all these crazy people that help us take care of kids every single day.
Everybody, thanks, Ann. It's a very cool view you have. It looks like you're almost in an aquarium in the back.
Well,
I want to thank everybody for being here tonight. I will tell you that the reason why that I'm so passionate about working with NuSmile is they honestly really care about us in pediatric dentistry. And if you think of product or something that you want or they need to innovate, you ask for it and it happens. So I'm a 2nd generation pediatric dentist. I am now 20 plus years into practice. And I spend about 70% of my time running my office and the other 50% of my time teaching and traveling and speaking and doing webinars and stuff like this. About 2 years ago now, I opened up a new office in a teaching center. So I think I'm up to like 15 courses a year now here locally, and we're having one. We're invading Bynum's Dental Emporium here pretty soon. We're doing a hands-on course there. So a lot of things that I talk about are different than Ann. Ann, her expertise is, a lot of things, but running a practice and practice management, and hiring and firing and all that good stuff. I stick with just fixing teeth. And I try to be an early adopter as well. And I'm very excited about being with you guys tonight. I will tell you that these devices have completely changed the way that I practice pediatric dentistry. And I don't say that very lightly. I barely do sedation anymore. I don't have tears. And I will tell you that 9.5 out of 10 children, when I give an injection to, literally don't feel it. So I am uber passionate about these devices and working with all you guys tonight. Where's my little go forward thing? I had it to advance and now there we go. You know what? I cannot advance. So Ann, you're gonna have to do that for me.
Yay, I'm in control. I love that.
We thought I got it working. Okay. And then super quick, that's my training center selfless plug, www.pediatricdds.com. And that's all I want to say because we got a lot to talk about. So let's keep on going. And that's my office and training center and let's just keep on going through this, Ann, because we want to get to the meat and potatoes of everything.
Who's that guy behind the microscope over there?
That's Vic and me in the upper corner.
It's you.
And that's my contact information. So one of the things if you don't already know this, Ann and I are very reachable. So if you email us, you message us, we will get back to you. Sometimes if I'm speaking for you, Ann, if one of us is traveling or we're, speaking or doing something, it may take a day or two, but we will get back to you. Both of us get emails and texts from you guys all the time. So that I think is as valuable as tonight. So if you have questions we don't answer tonight, if you're having problems with, anything you're doing as far as intraosseous anesthesia, I really beg you to reach out to us and we will help you. There's more help than you would need or want. Chris, you are batting, or who's doing the poll? Is that Jordan?
Yep, I'll go ahead and kick this poll off. Give me one quick second here. So that should be popping up on everybody's screen here now.
Oh, that's an old one. That's an old poll right there, but it'll work.
Oh, I thought we were doing the mastering one.
I just see it says Santa Claus on there, so that tells me that is.
Does it say Santa Claus? I might click wrong one.
I mean, we can pretend it's like Christmas in July or something.
Coming in 4 months.
Oh, the Santa one. I see it now.
You could still ask Santa for one. He could bring it early.
Go ahead. We'll roll with it.
I'll tell you what, one of the coolest things is, I mean, everyone can be, whatever your politics are, your politics, but 100% bonus depreciation again, people. Buy your equipment, get all your things. You can appreciate it longer. Oh, look at all the people that want one. I love that.
Wow, that's lower than okay, that's great.
Well, you know what? This might just be all right for what we have to talk about later on.
Yeah, very true. Very true. Santa might be running a special, huh? His little elves, maybe.
Anybody have a Santa hat today?
I have my scrub hat.
Awesome. So we'll give this just another minute or so. If y'all can go ahead and answer some of these questions here.
I don't see it moving.
Yeah.
Let's roll.
We'll go ahead and end this poll here. Oh, looks like a couple more answers. I'll let them finish the last couple questions here real quick.
Thanks for answering this, you guys. This really helps us tailor the presentation tonight. Although we have a set of slides, this really sets the tone of what we talk about. So actually, a majority of you do not have units yet. So we will lean a little bit towards newer stuff and talk to you about basics. Don't worry, we're going to cover detail things, but that helps us quite a bit. Thank you.
And I want to give a shout out to all of you on here. 11% of you said you use it on all your patients. That is our goal. Josh and our goal is to get you comfortable enough that you can use it on all of your patients too. So if somebody can be doing it, it can be done. All right, we ready to go on?
Yep, we'll go ahead and end that poll, and then we can go ahead and get rocking.
All right, so back to business here. We're going to do a mashup for y'all tonight. Get this off my screen. The other thing we're going to do is we're going to share some practice pearls with you this evening. And the first thing that we just want to tell you is, Josh and I, obviously, we're super high on NuSmile because they're super high on pediatric dentistry. But if you look at what they've brought us and how long they've been in our ecosystem, 1991 is when they first came out with these anterior signature crowns. They've been putting these products in our hands decade after decade. And if you look at 2025, if you really just look at these last 5 years, this is when they've really taken a a steep climb in helping us as clinicians for our patients. And we're just, obviously, Josh and I are privy to things behind the scenes, and we're so proud of the products they've delivered. And we're excited. Oh my God, my dog just jumped on the table to get a bone. It scared me. We're super excited to see what other products are coming in the future. So what is intraosseous anesthesia? I added this slide recently because I think I took a snoozer during dental school when this was taught. Actually, the students that are shadowing me this week, they're third years and they have learned very little about it. They have yet to give an intraosseous injection. And so I do feel like it's still very behind the times as far as learning this technique. So I really just, instead of having all these big words up here, I just kind of broke it down, and it just means into bone inject. That's what these words mean. We're going to inject into bone. So that is way less, it is not as scary to see these three words together as those big words up at the top of the page. It just means we're going to give an injection into the bone. Josh, tell us about this.
One aspect of intraosseous anesthesia we're going to show you tonight, I think that's very important for everybody to understand, is this concept is not new. I remember when I first got my units and I was excited to talk to parents about them, I had to remember that, in pediatrics, parents don't like necessarily new things. They don't want us, quote unquote, guinea pigging on their children. And just because something's new, that in the general dentist world, they get new tech all the time. And I think that's exciting for patients. But for our parents, the idea that I want everyone to understand is the concept of intraosseous anesthesia is not new. Now, having an electronic device and be able to deliver that local anesthetic into the cancellous bone with said device is new. But the idea of intraosseous anesthesia, this was published in 1906. And I think the important point here is that once we pass that needle through the cortical plate and we're into the bone space right near the apex of the tooth, the latter spreads in the mesh of cancellous tissue as easily as in a real cavity. Analgesia is immediate and absolute. It concerns both the gums, the jaw, the bone, the alveolar ligament, and the constituent parts of the tooth pulp and dentine. So the concept there, still in 1900, is the same today, is if you deliver an adequate amount and correct concentration of the correct local anesthetic into the cancellous bone, by the time you are done injecting, that entire structure and all the structures that contain around it will be numb. If you think about an orange, if you took the rind of an orange, that is the cancellous bone, right? That's your that's your plate. Once you pass through there and you get into that fruit, into where the flesh of the orange is, both everything inside and everything on the outside of that orange all become numb, right? And that's what we need to understand is once you pass that needle through, you deliver your local anesthetic, all the structures in that area are immediately anesthetized and you're ready to go immediately as soon as you finish injecting. And, we've had this amazing rise of the technology in dentistry, right? I went from having to take x-rays and go into a dark room, right, and use chemicals at the beginning of my career to what we have now. Same thing as far as scanning goes, right? Taking alginate impressions. I couldn't, I don't want to do that anymore. I want to use an intraoral scanner. We have not had an advance in the field of local anesthesia since literally the 1900s, but that's what we have today. So what do they look like? What you're going to find is just a matter of preference for these units. The business end where that needle is and the local anesthetic that we use is the same for both units. Just think about it in the easiest terms is one is wireless and one is wired. Most offices will wind up choosing the SOAN, especially if they have one unit. If you're an office like mine or Dr. Bynum's where you have a lot of these units, you may have some operatories that have a SOAN, some have Sleeper One. And because there's a lot of new people tonight, we'll get into that a little bit more as far as which unit we recommend to purchase.
Josh, what do you have?
I have both. I have a SOAN and Sleeper One.
You have one of each.
I have one of each. My preference, I like the Sleeper One just because I like the way it feels in my hand. I like the fact that I can see the light ring all the way around. A cord does not bother me, but it comes down to preference on what you want. They're both going to do the same thing. So they both have a pedal, and that pedal is not battery operated. Some people are asking about, does it need to be recharged? It does not. Okay. The container that holds that local anesthetic is going to be shapes a little different. The needle's the same. It really comes down to wired versus wireless. If you're going to just purchase one unit for your operatories and it's going to get moved around, which I don't necessarily recommend, not that there's anything wrong with that, but it's easy for things to get dropped from moving it to room. You'll find a lot of people, once they buy one, they buy a second unit. And if you have, one main operatory, you may want to decide on buying a sleeper one. It really is up to you.
All right. I got the first pearl tonight. This is something that I really can't take the credit for. I'll take the credit for developing an amazing team and continuing to do that. But my team came up with this. We are growing a lot. We've just added on to our practice. And what we've done is we're trying to make onboarding easier for teammates. And so what we did is we came up with a 30, 60, 90 template for our admin and for our clinical team. And each new hire gets, assigned a different team member that they are with for a week at a time, and they're helping develop these team members. So we have a 30, a 60, and a 90 sheet, and then the sheet gets passed to the next team member as they're continuing to onboard. So that team member can see, what are they struggling with? What have they got down pat? I don't need to spend a lot of time on that. Oh, Mayday, we need to spend more time on certain things. So obviously, in all of our offices, what we would expect our team to be proficient at in these timeframes would be different, but these just give you some good ideas and a starting place that instead of, overwhelming, it's so hard, we feel like, to find team members sometimes, and we complain about it a lot, but, once we do find that person, we sure don't want them drinking through a fire hose. We want to make sure we onboard them in pieces and properly so that they want to stay around and become part of our culture. So what benefits do these units provide to our patients? The biggest one, well, there's two, but the biggest one is no collateral numbness. You're never going to get a phone call again after hours that a kid is in the ER allergic to Novocaine. Like, that's just not going to happen anymore. No one's chewing up their lips. There's no numb cheeks. There's no numb lips. No one's, think of your special needs kids who have that tendency to want to scratch or pull or bite their lips and cheeks. That is no longer a concern anymore. So what benefit do they provide to us? The patient is numb immediately. Obviously, that's a huge benefit to the patient as well, especially if they're, a little one and they're anxious and nervous, and, you got a parent staring down the barrel of your chair. It is nice to have the patient numb immediately for everybody, but especially for that patient and especially for us. We can stay on top of our schedules, and we can get that chair turned around quickly. Josh, hit us here. Tell us some of these things.
Perfect. Let's get through this. So as I mentioned in the beginning, I can tell you without equivocation that I don't want to say 10 out of 10 because I don't, I have to put a little bit of fudge factor in there, but 9.5 out of 10 patients, now that I'm comfortable with delivering local anesthetic intraosseously, do not feel the injection. I will have two, and sometimes people don't believe this, but I'll have 2 and 3-year-olds where I've got to extract ENF that I used to treat those kiddos with oral conscious sedation or intranasal sedation. And now majority of those children I treat awake. If you follow all the rules, and we'll show you that tonight, as far as positioning, as far as hand position, as far as knowing where the needle is supposed to go, if you follow the rules, I can tell you more often than not, your patients will not react to the injection. Now, they may feel a little pressure. Pressure is normal, but they will not feel pain. The thing we need to remember is once you pass into the cancellous bone, there's no nerve endings there, right? So if you have a patient that makes a little bit of noise, they may feel some pressure, although these units will keep you safe and they will never overpressurize that system. They'll never let you give more local anesthetic than that's safe as far as the not the total amount, but as far as the amount of pressure. But you should not have patients that are having pain whatsoever when you give these injections. Anne already mentioned no collateral numbness. I've been using my units now for 14 months or so. I've yet to have one patient that's had a numb cheek or a numb lip. And I tell them they can eat right away, as long as I'm not waiting for a crown or something to set up. Most of my patients is you can go ahead and eat and drink right away, which is amazingly powerful. And it keeps parents happy right before lunchtime, so they're not having to, figure out redoing lunch for their kiddos. As far as practice management goes, I will tell you these units pay for themselves very shortly. And what we do in my practice is, we have a lot of time for an appointment. And if that child's doing okay and we have time to continue and do other stuff, we check with the parent. Mom, I happened to meet 2 times today. We finished one quadrant. We'd only planned for this. We have extra time. Let's do the other. Well, I was working on S&T. Normally, I would have rescheduled that patient because I don't like to give bilateral blocks. I just don't do it. You don't have to worry about that anymore. Because you're not having a numb lip or numb tongue, you can add that second quadrant without issue, and that patient's immediately numb. So as soon as you finish that injection, you come off the pedal, the needle comes out, you start working pretty much right away, okay? And a number of appointments should decrease. And again, that is going to help pay for these units very quickly. When we talk about immediate action, as long as you're giving enough of a volume of local anesthetic, and we'll talk about that tonight, you should get immediate delivery. Now, we need to make sure we're checking x-rays and all those things that we're delivering in the appropriate spot. But if you follow all the rules, you should be able to take that needle out and start working right away. And if my patients are happy and my parents are happy, then everybody's happy at the end of the day. I'll show this case later on, but this is the one case that sold me that I would never never extract primary teeth with a standard syringe again. So this patient was 8, not a happy camper. I'll talk about it a little bit later, but I gave 1 intraosseous injection. Patient did not feel it at all. Took out NOPQ. Patient did not react, and everybody was in tears by the end of the appointment, being happy. And not having collateral numbness, Anne already mentioned it, that we've all gotten those calls of, yes, they went to the ED and your child's allergic to anesthetic, and immediately you're going to have to get on the phone with your malpractice carrier because you've got a parent that's mad that you gave your child a bad drug and they had an allergic reaction to it. If you follow the rules, you will not have an issue with having collateral numbness. So these are the 2 devices. Now, one thing that's really cool is they come with this thing called an instruction guide. And what I beg all of you to do is to actually read it. And I say that not to be flippant, but a lot of the questions that we get are covered in the onboarding. I'll just mention that for a second since there's so many new people tonight. You will have more help with these devices than you ever want or need, okay? And once you purchase one, it will come with an onboarding process where they don't just hand you the unit. There's videos to watch. You can do onboarding with the team at NuSmile, and you should have all the information that's needed to be proficient with these units right away. I do recommend not having your staff, don't delegate. You need to do this yourself. You're going to be using these every single day. We have color guides on both the units that are available to you. You can download them easily online.
And I just like to jump in and say something about that as well. We are, like I said, we're growing our practice right now and getting the onboarding right for the new people. This is not a cheap device, thing that you're bringing into your practice. And it is like a very smart computer, and there are things on it that can break. And getting the plunger put back into the holder before you're trying to take the anesthetic carpule out is vital. And if you just got people tearing into this and, trying to pull it apart, you're going to be very sad when something happens to your new favorite toy in the office. So let's talk about how the device works actually. And if we're giving just traditional anesthetic, we have to go into the tissue. We're giving a blind injection. Even with lidocaine on board, we know that anesthetic, that solution is dispersing everywhere. We're crossing our fingers and turning our back and very hopeful that enough of it will travel through the tissue and through the bone and get to the nerve and get our tooth numb within 5 to 10 minutes so we can get started. With these devices, let's see, what you're going to see is that it's going to help hold that anesthetic at the site. It's going to deliver the anesthetic through the bone right to the apex of the tooth, and we're going to have much more profound anesthetic earlier on.
And I threw you for a loop there. I added one quick thing onto
Yeah, I
that.
saw that.
Sorry
I'll go
about
back.
that. Didn't tell you. I wanted to mention this early on because this is for those of you that already have these units. And we'll talk about local anesthetic choices later, but the key concept here is with traditional Septicane, which is 1 to 100,000, that when you think about what that epinephrine does, it's going to close off the vessels. So it's going to keep that anesthetic from spreading as far. So there's early on, most practices right away are going to buy Articaine in 2 different concentrations. So both 4%, but 1 in 100,000 and then also 1 in 200,000. And do you keep both in your office?
We do. We have both.
Yeah. And we'll talk about later on how to make those choices on which anesthetic epinephrine concentration to use. Oh, I'm talking. Okay. Key point here is that when we give an intraosseous injection and we actually when we inject into that cancellous bone on the maxilla, there's an omnidirectional flow of local anesthetic, meaning that if I was going to deliver my local anesthetic here between the premolar and the molar, I would expect to have 2 teeth distal and 2 teeth mesial that are profoundly numb. All right. So both directions, you're getting an equal spread of local anesthetic. Now on the lower arch, it's a little different. Because there's a bias of blood flow from mesial to distal, you're going to have 1 tooth distal and 2 teeth mesial that you can pretty much guarantee that you're going to have profound local anesthetic. So the upper arch, it's 2 and 2. On the lower, it's 1 distal, 2 mesial. One exception to the rule here, and I think it's an important concept for people to understand, is with a teenager that's almost an adult size, you may not get the same amount of flow on the upper and lower arch. And we'll talk about that here in just a little bit. But in general, it's 2 teeth mesial, 2 teeth distal on the upper, and 1 distal and 2 mesial on the lower. I think it's important to understand some terminology and lexicon when we're giving these injections. So when we talk about an intraosseous injection, right, where it means we're, instead of like we did before, we would deliver that bolus of local anesthetic into the soft tissue and it would perfuse through the cortical plate into the cancellous bone, we are skipping that soft tissue and cortical plate and we're delivering right into the cancellous bone. When we talk about these injections, really we're giving an osteocentral injection. That's at least the goal, is to get past that cortical plate to be able to give that local anesthetic in an area where we can maximize the amount of diffusion. The thing that we need to remember here is these units are, essentially mostly designed for primary and mixed dentition. Now, does that mean you can't use it for an older patient? Absolutely not. But the rules may change just a little bit as your patient gets older. And what I mean by that is we're only using a 9mm needle here, okay? Now, with a 9mm needle for a teenager, you may not be giving a full osteocentral injection. So I will pretty much guarantee you that for that teenager or adult, if you can get the needle through the bone, you're going to be able to anesthetize 1 tooth mesial and 1 tooth distal. We do get questions where, how come I'm not getting a whole quadrant numb for a teen? Sometimes you do, but again, with the needle, that this 9mm needle is, you may only be getting a interseptal injection, which means most of that local anesthetic is just going to be in that interseptal bone numbing 2 teeth. But our goal always is an osteocentral injection. Thank you. Anne, are you talking?
Yes, it's really a 3-stage injection. This is how you want to think about it. The first part of the injection is you're injecting just into the papilla. And your goal there is to get that tissue numb and to get that periosteal bone area numb before you do the next part of the injection, which is going to be your intraosseous part. So part one is just you're going in with the needle. We're going to show you how to do that to get the first part numb. Then you're going to come out, you're going to rinse, and then you're going to go back in, and you're going to make sure that you are into the bone before you step on the pedal again to deliver anesthetic. So it is 3 separate parts: numbing the papilla, penetrating the bone, being confident and sure that you're in the right place, you're actually in bone, and then the third part is to deliver that portion of the anesthetic into the bone. So when we're injecting into the papilla, this is what the pedal look like that Josh talked about. Doesn't matter which unit you get, they basically look the same. You've got the outer pedal and the inner pedal. And what you want to think about is that inner pedal is small like the papilla. So you're going to be stepping on that inner pedal.
That's a good one.
Yes. I taught these residents this week, okay?
I learned something
so you're
new.
stepping on the inner pedal to deliver that first dose of anesthetic to numb the papilla. And then when you're going to, once you're, you've come out, you've gone back in, you found you're in good bone and you're ready to deliver anesthetic, you're going to step on the outside pedal. The white line means nothing. It's just if you're, driving on the right or driving on the left, depending on if you're probably a right or left-handed clinician. So we're going to show you here. This is showing you that stage 1 where we're injecting into the papilla. You're just laying the needle in. You're not advancing it. You're not poking it. You're kind of just like slowly melting it into the tissue right there. That's the goal. And I put this x-ray up because Josh mentioned it earlier. You got to have some bone, people. If you don't see bone anywhere, if you got a hot mess and there's a hot tooth and no bone around, you got to punt. You got to either go, a tooth back or a tooth forward and find some bone, or maybe you're just going to do an infiltration if it's, if there's no good bone around. But here we do have some good bone. I am showing you that. And this is the same patient. It's just the other side of the mouth. It was just easier to show it when I was making the video. This is actually my husband's assistant's kid. And so I'm going in, I'm tugging on it. I want to make sure that it's in. It didn't feel like it was in. So now I'm going to twist it some more. I want you to appreciate how close my hand is to what Josh calls the business end of the device. You are super choked up on these devices so that you have really good tactile sense. And now I'm confident. I'm like, okay, I'm in there. I've got about 1 millimeter of needle still sticking out. So I'm confident that I don't have it buried. I can still have eyes on it. People freak out that they're going to break a needle. It's just not going to happen. But, I can see my needle as I'm giving the injection.
And hypothetically, I have a question for you, because we get asked this all the time. Let's say, I've never seen this happen, but let's say you did break a needle there, right?
Yes.
What's going to happen?
I'm going to pee in my pants a little bit, and then I'm going to get a hemostat, and I'm going to pull the needle out, and I'm going to put a new needle on the unit, and I'm going to go again.
That's what the one fear I want to allay for everyone is, hypothetically, child moves, the needle broke, right? I would much rather have that needle sticking in bone where I would have to physically grab that how plier and pull that out versus a block, and the pterygoid muscle sucks that needle back under the soft tissue. So I don't want people to worry about breaking needles.
Yeah, I feel the exact same way. I never got my, in a wad about breaking a needle for an inferior alveolar or an infiltration. And by God, that would be much worse. It would probably be a bigger needle, and it would be floating around in the, cesspool of tissue and nerves back in the cheek somewhere. So this is, I feel like a better solution. Again, just showing some more videos. The D is really important. The D needs to be facing out when you're giving this first injection. And this is Dr. Nash in our practice. And again, he's way choked up on that needle. He's twisting it. It's just helping it. It's just, you're just helping it pass into the bone a little bit more.
Wait a second. I learned something new too. That's a great idea. Tapping with the slime ejector for distraction.
Right, that's 30 years. That's 30 years for you right there.
Wow. I'm not being flippant. That really is a great idea.
Yes, we do. We distract kids all the time.
That's great. All right. I'm stealing that tomorrow. Thank you.
All right. Well, that was a pearl right there. So here's another pearl for you.
So really quick, this is one practice pearl. I think it's tied into these units. And for those of you that already have established practices, I think especially if you're for yourself or if you're bringing on like Dr. Bynum with her growing practice, when you bring on associates, often the time it's going to take myself versus maybe someone new to the practice to do a certain procedure, perform a certain procedure can be different, right? And you really don't know unless you time these things out. So one thing that we do in my office, anytime that or if there's a new procedure, is we actually take a real inventory of time. So you can see this is all the things we write down, what the patient's scheduled for, what their appointment time is, when arrived, all the way down to 12 procedure. And that also includes turning that room over. And you want to put that into this calculation. And very strange. And so what happens is that time, how long do, one or two rounds. And then scheduling wise, make sure that your team schedules those truly what those appointments need. So you may have procedures that in your practice are getting scheduled for an hour that you may only need 40 minutes for, right? And vice versa. You may have procedures that are timed only for.
Hey, Dr. Solomon, we seem to be having a little connection issue with you.
Yeah, Josh, I think we lost you here for.
All right, I'll keep going here. So basically,
there we go.
It is a great idea if you really want to not get in the weeds, but if you really want to see how productive you are, if you just don't believe, if you're just not sold on this, this is a great way to see how much time you're saving and what a better job you're doing for your patients. All right. So let's, again, talk about, we're going into the mucosa here. And what you want to kind of do here is, I'm going to go back on that slide actually, is you're going to like lean into that papilla and you got to think, I want the very end of that needle tip where the anesthetic is going to slowly drip out of to be equidistant in the middle of that papilla. So when you're sliding in like this, you're kind of like going in from the side and your target is where that red line is right there. But again, you're sort of just bending the needle in. You don't want to be poking as you do it. And this is probably the biggest learning curve, in my opinion, is to give this stage one. Stage two is not going to hurt if you get stage one right, but stage one, I mean, there is a learning curve with it to get it so that you are making your patient comfortable. I would definitely tell you to keep using topical as you're on this learning curve. I do not use topical anymore, but I've been using the device for, very close to 2 years now. So that's one less step for me, is getting out a Q-tip, putting jelly on it, all that stuff. I don't have to do that anymore. So let's talk about the blinking lights that are on these units. So this is the Sleeper 1.5, and it's called a 1.5 because it's actually in its fifth evolution, and they're just constantly making changes to it. So I'm very confident that the Soen, the cordless version, is eventually going to get a facelift or two as well. So that's why it's called the Sleeper 1.5, but it does have this blue light on the end of it here, and the blue light is telling us bone. Just think of blue as bone. So when the blue light is lit up, you're using this to deliver intraosseous injections. You can also use these devices to give infiltrations, PDLs, infraalveolars. And so there's a way on the foot pedal for these devices to change the setting. So you can click it with your foot, you can change it to pink. And when it changes to pink, that's telling you you're going to use it for a PDL. And then I was telling you also, you can click it again and you can change it to orange. And now we can give an infiltration or a block, should we so want to. I would probably tell you orange. I use that if I've got like a coronal remnant and I know I don't have any bone around and I don't really care about going 2 teeth back and injecting into bone. I'll just use it and I'll just go around that tissue to get out some little, coronal remnant that some kid couldn't get out of first molar on their own. and it's in pieces. So here's the sew-in. It does look a little scarier and a little bit more robust. One of the things that we're all hopeful for is that in the next versions that the lighting feature does go circumferential around the device so that you can see it at all times when you're using it. But same thing, blue is for bone. This little blue light's going to light up when you turn the unit on, and that'll tell you that you're in the intraosseous delivery mode. And then pink or purple, it looks different in different lighting, is what you're going to use for infiltration. So there is no orange on this device. The lights also tell you things as far as how much pressure the anesthetic is feeling as it goes into the bone. And again, think about it like a little kid, like 3 or 4, that bone is way more porous. So the chances of the device building up with pressure is a lot less than it is for, as you get up in age and your bone becomes more cancellous. So if you just have one light and it's going to flash when you put your foot on the pedal, it's going to flash. That's going to tell you how it's working. So if you've got one light, you're a go for launch. If it's starting to flash 2 lights, it's just telling you it's starting to feel a little bit of pressure, but everything is still okay. If you start seeing 3 lights starting to flash, this is where you need to start paying attention. Things I would tell you not to do, and these are pro tips now. These are for people who have the units, but something to remember when Santa does bring you your unit is don't freak out, don't pull the needle out, don't take your foot off the pedal. Every time you take your foot off the pedal, the device has to start over at a longer cadence. Usually when you start the device and you put your foot on the pedal, it's going to start off really slow. Once it realizes everything is safe, it's going to increase the speed that it's delivering the anesthetic. You take your foot off that pedal and you're back to 0. You're starting over. So it's a longer injection for you and the patient. Hang out here for a little bit. Let these 3 lights go on. This is a very smart machine. Give it time and it will usually fix itself and you'll see those dots go down. If you don't see the dots going down, then you do need to, the first thing I would recommend doing is readjusting. Just pulling back a little bit on the needle sometimes is all that is needed. The second thing you can do is you can take your foot off and put it back on and start it over. And then the third thing is maybe you've got some bony spicule in the needle or the needle has been compromised and now you do need to take the needle out and put a new needle on. If you get to 4, and the device can't figure it out, and you can't figure it out, and you're just in space or something, not paying attention, and 4 lights start to flash, and nothing's being done to fix it, the device is going to shut itself off. So it's not going to, like Josh said, it's not going to allow you to harm the patient if you're not paying attention to what's going on.
And can I make one point? These are the only devices that have FDA clearance for intraosseous delivery of local anesthesia. So there are other devices on the market that look somewhat similar, and they're electronic delivery of local anesthetic. The problem is none of them are designed or licensed for delivering an intraosseous injection. So my general rule is if you can buy it from eBay for $200 along with tires and other things, probably shouldn't be buying it for your practice. But in all seriousness, this is a drug delivery device for children, and you need to use devices that are licensed for that procedure. Those other devices will just keep on giving. They don't have the same algorithm in checking the pressure as many times as a minute as these units do. So let's talk about, we can skip past topical. I can just tell you, I don't use it in my practice. I did for about a week just to make myself feel better. And I just don't find the need for it. The only time, maybe if there's, infected tissue and it's already, over-retained tooth, and I'm a little concerned, maybe I'll use topical if my assistant gets it out, but very rarely do we ever use it. But let's talk about local anesthetic choices and why we use certain local anesthetics. Did we get this going? Yeah, you have to click forward for me there, Ian, because I can't do it. All right. Since the 80s, we've been using Articaine in the United States. We do get questions about, well, what about children under 3? We all use Articaine, and the only reason why that Articaine, in the IFUs, it says for children, 4 and over, is for the fact that nobody volunteered their babies to have some Articaine injections, right? You have a DR in front of your name if you're using one of these devices, and you get to make a decision on which anesthetics that you use. And I will tell you, not only in this country, but we're one of the latest to the game to get these units, and everybody's using Septicaine at 4%. And there's some definitely reasons why. We won't get into the details in the chemistry, but we do know that thiophylline ring makes the local itself much more soluble. The other thing that's important here is that Articaine is metabolized in the plasma and not in the liver for safety profile. Now, once you buy your units, actually, let me talk about this first. One of the things we need to remember about Articaine itself is, the elimination half-time is lower. And that's just because of the fact that a majority of the metabolism here is in the blood itself. And we can actually go past one more slide here. Now, which concentration of epinephrine do we use? So Articaine in the US, at least, comes in it's all 4%. So either 4% Articaine with 1 to 200,000 epinephrine, or 1 to 100,000 epinephrine. I'll tell you what I use in my practice is a vast majority of the time, I'm using 1 to 200,000. When I'm using 1 to 100,000, it's either for if I want to extend the treatment time a little bit, although if I was really worried about that, I would just give another little bolus of local at the end of the procedure. But it's mostly if I'm doing extractions, especially extractions of hot teeth, I'm going to use the 1 to 100,000. Everything else, everyone's getting 1 to 200,000. If we go back to that slide at the very beginning where we talked about the electronic delivery, it's a very easy concept here, is that when you're giving that drop by drop local anesthetic delivery, when we have a slightly higher concentration of epinephrine, our fluid bolus stays more localized in that one area. Now, that's going to be important for an extraction because we don't want to have as much of that local anesthetic perfused into other teeth, right? I want to make sure I've got profound anesthesia in that one area, all right? So that's why I'm using 1 to 100,000. If I'm going to numb multiple teeth in a quadrant, I want to use the 1 to 200,000 because I do need a larger spread, not by much, a couple teeth here or there, but I want a larger spread of local anesthetic. The nice thing is because if you buy, the Septicaine brand, the little color tab on that anesthetic looks different than the 1 to 200,000. So if you look at the carpules themselves, the color is different on there, so it will differentiate them from each other. Good. This is just one quick suggestion that one of the docs made. If you have a SOAN and a Sleeper 1, the containers where the local anesthetic is contained in the carpule, they're slightly different size. So some practices use these. I know in my office, we have one blue and one purple. The other thing that you can do is, and Ann will get into this, if you don't have your unit set to deliver an exact amount of local anesthetic, you can mark your cartridges. And that way you know how much local anesthetic you're giving. Most people choose to have a defined amount programmed, and Ann will talk about that.
I'm not sure Ann's going to talk about that, but yes,
you talk about cruise and
something Aaron and Jordan can talk about when you get your units. You can program it so that it will stop at certain intervals along the way.
We don't talk about that in cruiser driver now. Okay.
Not a whole lot, but so one of the things that people, one of the barriers to entry for these devices we hear is that, oh my God, it just goes so slow. And it is going to feel like that, but I want you to appreciate that it's really on average delivering 1 mil per minute. So about 2 minutes start to finish if you're going to give a full carpule, which I'm not giving full carpules. Like I really couldn't tell you hardly any time where I've let the whole carpule just go and empty and then the plunger just retracts itself. I mean, I'm a quarter carpule girl for a class 2. I'm a half carpule girl for maybe a stainless steel crown and a pulp. And I'm probably a 3/4 carp girl if I got a hot tooth going on. But I'm not, you just don't need a whole lot. So that cuts down on time as well.
Can you say that one more time? Because I actually love, that's a perfect summary. And I think it's important for people I think that's a perfect summary on how much local to give. That answers the
Yeah,
question. You
just
want to
like
say
a
that one more
class
time?
1 or a class 2, a quarter carpule, a pulp and a crown, probably a half a carpule, and any sort of a hot tooth situation, 3/4 carpule.
And that's exactly what I do as well. And I think that's an excellent rule to follow. You can write that one down.
So this is Dr. Megan in our practice, and I definitely have this sped up for you, but I want you to appreciate how this visit is. From the time the kid is in the chair, nitrous is on, she's given the injection. You can see the blue light blinking. That's a perfect visual of it right there. Now she's giving stage 2. That's
Does not move.
that's probably like a 3 or 4-year-old. Doesn't care, eyes not blinking, no sign of any discomfort. Isolite going in. The other thing is you can have your isolite in first if you want, and you can give your injection with it in. It's totally up to you.
That is a great pro tip. I didn't start doing that until halfway through, and I wish I knew that early on.
She's digging out some decay. Curing it. Smoothing. One, 2.
And you notice that child did not move. I mean, even from the pressure.
Nope. Whole entire visit, 7.5 minutes. And this is what the sockets look like. You don't have bloody running. Now, granted, the kid's not wound up and going nuts, but I mean, the sockets look so nice. There's such little seeping and bleeding going on. So there's a 7.5 minute visit right there. We schedule 30-minute ops. I can get that chair turned over, and of the 7 recalls that are in the bay, I can now put somebody else in this operatory.
And the beautiful thing there too is if you needed to add, let's say he did better than you thought he was going to do, and you needed to do S&T, instead of sitting there giving a block, waiting 5 minutes, you deliver your local anesthetic, you add S&T, needle comes out, you're good to go within 3 minutes.
Yes. So this is Dr. Nash seeing this patient, and it was his first time taking out a permanent tooth. So he was a little more nervous about it, I would tell you. So he did inject on both sides of the premolar because he just wanted, for his own sake, to make sure that the patient was totally numb. Again, kid doesn't flinch, nothing to it. Pressure using an elevator on the lingual, both sides. Tons of pressure. Tooth is out in less than 7 minutes. The mom's probably like, what did I just pay for?
Yeah.
This is, even though this is sad and hard to watch, this is the most compassionate thing you can do for kids like this. Before we had these devices, you would have to numb this kid. Then in our office, we would let the kids sit up, cry in their mom's lap for 5 to 10 minutes. We'd leave the room because we don't want to hear the kid cry and pretend to check a recall or do something. And then we come back in the room and have to lay the kid back down. And the kid knows it's coming again, right? They know there was the appetizer. Now it's the main course. Now it's all wrapped into one. And this sucks. This sucks for all of us. None of us like having to do this. But that was 2 minutes. Nurses can take longer giving vaccines than we can doing something like this. So just don't tell me that it takes a long time, because it just doesn't, and it's super compassionate.
So I mentioned this case earlier, and this was what sold me that I could never use a standard needle again. So I can tell you in the last 14 months, I have used a standard needle 3 times, I think, total on a patient 14 and under. And that was because my associate had the sew in the another room. Okay. And that's busy practice. So there's much op that I do all day. So this kiddo, 8-year-old, and mom came in tears, patient came in tears. Mom had a ton of dental trauma. Of course, she then passed that over to her baby. And previously, this would have been 3 or 4 injections in my hand, right? This would have been Septicaine, and I would have used a short needle, and I would have given a couple injections there in the vestibule, and then probably 3 or 4 injections on the lingual. And literally, this patient was no topical, nitrous, came in laterally, and gave our first stage where we're just numbing the soft tissue, angulation change, manual bone penetration. And I gave, now in this case, I chose to use the 1 to 200. Teeth weren't infected, but I wanted to get a good spread of local anesthetic because I was giving 1 injection, that's all. Needle came out after giving a half a carp. Immediately, NOPQ, child did not move, didn't even feel the pressure. The amount of profound anesthesia that I get, it's different giving injections interosseously. All 4 teeth came out. Patient did not move the entire time. And like I said, at the end, mom's in tears and patient's in tears, and that's not because things hurt, as they were happy at the end. If these units only allowed me to anesthetize anterior teeth on little ones or ones that are nervous, that would be enough. There we go. All right. So one concept for everyone that's new that I want you to understand is that this is not much different than what you've been doing already, except for when we give a local anesthetic in the soft tissue, into the vestibule. If you think about how things travel, it's that bolus of local anesthetic needs to go through the plate and pass all the way through that plate into the cancellous bone and then down to the apex of the tooth. What we're doing here is we're skipping that. And this is why that anesthetic is that profound anesthesia you're getting almost instantaneously, is we're passing through the plate and we're giving it into that cancellous bone and very close to the apex of the tooth. Once we deliver the local anesthetic, the tooth is getting numb immediately, and then we are having to give that bolus, and that bolus of anesthetic is now traveling backwards on, let's say, on the lingual side, going from the bone to the soft tissue. So we do get some questions about, well, why isn't the lingual numb? You should be getting profound anesthetic with 1 injection in that quadrant. If you don't, it may mean that number 1, you're not in the bone, or number 2, that you need to deliver a little higher amount of local anesthetic. So if you're not getting what you need with a quarter carp, this may be something you just need to see what you're comfortable with. You may be giving a half. But like Ann said, I rarely will give more than a half carp unless there's a big infection in that quadrant. So palatal access. If you would have told me I would be giving any injections in a pediatric practice on the palatal side, I would have thought you were crazy. But I will tell you, I do this routinely. If I'm right-handed, so if I need to deliver to I and J, it's much easier for me to see the lingual surface of those teeth on the left-hand side. You can give the same steps. So the initial papillary injection, change, our angulation, manual bone penetration. And sometimes it's actually, I find, easier to get through the palatal. You'll get the same effect. That whole quadrant will get numb and your patients will not feel it. So don't be scared of giving this on the palate. You do what you've got best vision for. Some people say, well, I'm right-handed, it's tough for me to see on the left-hand side. Fine, give your injections palatally. You may worry you a little bit the first or second time, but after that, I promise you won't even think about it. It'll just become rote. You just have to do it. And I think in here it says, yes, it works. No, it does not hurt more. And don't be a baby, just do it. And especially we talked about if you have an infection on the buccal, you don't have organized bone there. So if you're finding that you've got a draining fistula on the buccal and you try to inject in the area, you may have an issue getting profound local anesthetic. Don't overthink it. Just go wherever the bone is more organized and most dense, and that's going to be on the palatal side most of the time. So infiltrations for abscess teeth. You just need to, I think I already mentioned this, you just need to go wherever you have organized bone. just like with an extraction, you're never going to take out a tooth unless you see a radiograph first. You want to see, if there's bone in that area, if there's, if you see a big lucency, that may not be an area that you want to inject to. You may decide to go one tooth more mesial, one tooth more distal, but as long as you get through that plate into the cancellous bone, if you're 1 or 2 teeth away from where you're wanting to work, that's okay. One big hint here is second permanent molars. As patients get older, their cortical plates are much thicker. So if you remember, as that tooth's erupting, you may have a thin plate on the distal of that second molar, and I'll routinely give my intraosseous injection into the more distal aspect of that tooth because I know it can pop through almost every single time. You can use these units on patients that are older. Right? Remember, we're not drilling through bone like you did with an X-tip. If you use one of those devices, it's manual bone penetration. So you need to get through that plate wherever it's the thinnest. And you can do it for most patients. I mean, even if they're a little bit older, but it may take you some work. Please remember, if you have an issue with, you can go ahead one slide. If you go to give your manual bone penetration and you're twisting and you can't get through, take that needle out, put a new needle on. It's going to cost you 27 cents, but I promise it's going to make your life a whole lot better. You've got to, once that needle is so long and sharp, once you use it once in one quadrant, if it's not going to go through, take it off and put a new needle on. And prime example here, right? Sometimes you may need to give in 2 sites, or you can give palatally here if you feel like that you just don't have good organized bone there on the buccal. And palatal approach, we already talked about this. I just want to make one quick point. When we teach the first stage on that papillary injection, you're going to see that all the training is showing that injection horizontal. There's a reason for that. It is much safer to give that injection horizontally than it is vertically. When you first learn, especially, you may get heavy-handed and start to push that needle into the bone instead of injecting superior to the bone. So although this is showing a horizontal or vertical approach, you've got to be careful if you're giving your stage 1 here, because you don't want to touch that periosteum unless that's very numb. So just be careful in finger position. This is showing, you don't see hands here, and that's just because of the photo. Anne mentioned this earlier. I'm going to grip as close as I can to the junction of where the cartridge is and the needle itself. Lingual approach, same thing. You just got to go wherever you have the best access, and you can absolutely give these injections in the lingual. It's not an issue. It's the same steps as you would on the buccal. Over delivery. So for teens especially, I would highly recommend just using 1 to 200,000. And the reason being is that we're mostly going to be giving an intraseptal injection with a 9mm needle to someone that has a full permanent dentition. If you over anesthetize in that papillary area, it is possible to have a little tissue sloughing. Now, this patient, I think they were a finger picker, and this is likely because my Molly used to do that. But you do want to be careful on how much local anesthetic you're giving into that papilla. That first stage should take you 5 to 10 seconds. That's it. Once you see blanching, you're good to stop.
I kind of already went over this while you were
Correct. Keep going.
with the Wi-Fi. So here's another one of my pearls real quick. This is thanks to Jeanette Budd. Some of you know her. Great idea, especially if you're growing a practice. Get these magnets, get your logo on there, give it to all your new patients. Parents love it. Just, trying to give you some ideas for how to get your name out there and promote your practice and do something that's different. I also run the Tot Spot. That's my airway center. And, just having swag, having, things that are different. You just want to do things that are different that somebody else doesn't have. If you got 5 pediatric dentists around you and everyone's giving out cups and chapstick, then what sets you apart from everybody else? And that's why these devices are great too. I mean, you are completely setting yourself apart when you have these in your hands. So let's talk about the difference in drive and cruise mode, because people ask, why is it stopping at a quarter carpial even if I'm in the drive mode? The foot pedal, think about your foot pedal for your handpiece, right? When you put your foot on that, your motor runs and you're drilling into a tooth. And that's exactly how this foot pedal works as well. If you keep your foot on the pedal, you're in drive mode and the device is going to deliver anesthetic. If you want to have the device put into cruise mode, you can do that. And that's where Jordan and Aaron come in super handy to teach you on that. We're not going to definitely get into the weeds on that tonight since many of you don't have the devices yet, but just think about it like a car. If your foot is down on the pedal, that's drive mode. If you're tapping the pedal and coming off the pedal, that is cruise mode. I used to think I wanted it in drive because I wanted it like my handpiece. Now I hate keeping my foot on that pedal for however long I have to keep it on there. I like to just tap it and I don't know, do whatever I want. A little salsa, go over, check the computer. Because you're literally just holding the device in the kid's mouth, waiting for the anesthetic to deliver. So it just kind of frees you up. So just, you can pick those things. But one thing I will tell you is if you leave it, in cruise mode and you take your foot off the pedal, and it's in cruise mode, the entire carpal of anesthetic is going to finish delivering and into the cap of the needle. So just remember that if you are in cruise mode, to make sure you tap your foot back on there to shut it off before you're done with the device. Just some marketing ideas here. We can, calling it a magic wand or calling it that you're going to take someone's temperature is a great way to market it. NuSmile's come out with these brochures that you can purchase. This is what we have. We have this hanging up. Parents don't come in our rooms for treatment. They stand outside a window. And so we have a big sign outside the window. So they're reading like what is going on, what is happening here, what are the advantages to why their kid's getting this done. And this says up at the top, why are my patients having some discomfort? I mean, it can be any number of things, and that's what we're all here to help you with. Sometimes it's just they're not numb as long. So, when patients were numb longer and they left your office, you were like, skeet, I'm an amazing dentist, and then one's hurting. But when anesthetic wears off, if you've clubbed a kid up and you've pulled a tooth and done a pulp and a crown and, done some pretty aggressive dentistry, I mean, their mouth is going to be sore. So if your kid's coming out of anesthetic in 30 minutes, they may, be whining a little bit afterwards and you just never really knew that before. And it could just be because you've done some heavy dentistry. Also, at the beginning, when you're learning to do this, you are going to be stabbing your patient a lot more. You're probably going to really irritate that tissue more and irritate that bone a lot more. And some of your initial patients, I mean, just think about your first patients you saw in dental school. Those patients were probably more sore than the patients you see now. So that's just part of the learning curve. It should get better with time, or you're in the PDL. The PDL is not a cool, fun place to be. You need to really, know your anatomy, practice your angulation here with these devices, because we don't want to be giving PDLs. That's a lot of pressure to be delivering into that space.
All right. Really, I know we have mostly people new. I'm just going to go over this quickly. This is my mantra that I go through every single time when I'm going to use my device. So the first thing is I'm going to pick it up. I want to make sure the power is on. The reason for that is it will auto shut itself off to keep the charge. And it's kind of a bummer if you go ahead and give your stage 1 and you go to step on the pedal and nothing's happening and you forgot to turn it on, because now you've got to come off and turn the unit on. So number 1 is the power on? Then I want to look at the radiograph, make sure that I've got good bone in that area. I'm going to choose my injection site. I want to make sure I have the right anesthetic loaded in. If my assistant, if someone's new or they didn't remember on which concentration epinephrine, I may want to check that. As far as suction goes, Anne made a great point tonight. Leave your isolite in. I do that if I'm going to use the isolite versus rubber dam. I'll put the isolite in first and then go ahead and give the injection. You've got good lighting and good suction. Before I give the injection, I want to make sure my pedal's in the right position. One of the quote unquote problems is most of us are using big fancy dental chairs that are super thick, that have metal and fabric and cardboard and wood. If your unit is directly under your chair, it may have an issue talking with it. I'm sorry, if your pedal is directly under the chair, it may have an issue talking with your unit. So I do like to just step on it first before I actually give that stage 1, just to make sure that it's communicating. So I want to see a beep and then I'll stop. And then lastly is what's my position? Do I need to turn the patient's head? Do I need to turn my body? Do I need to make sure that my assistants are helping cradling that patient? So power, plan, pedal, and position. However you want to do this yourself, it's fine, but make sure the unit's on. Make sure that you have the correct local anesthetic. Make sure that you're checking for bone. Make sure that your pedal is communicating and that your patient is in the right position, and then you go.
So what are some things that you can get out of your own way so that you can buy these devices? It's going to make you money. It's going to cost you a little bit of money, but it is going to make you money. We have 3 doctors working every single day, and all 3 of us are working in at least 2 treatments a day, at least. And that's a really nice thing to be able to tell a parent who's taken off from work and is there for a recall that, hey, we've got time to do this today. That could mean a full day or a half day pay for some parents. So what do they cost? We've got this up here for you. And the price goes down if you buy more units at the same time. The sew-in, the cordless version, is a little bit more than the sleeper one, but still extremely reasonable. And we have an offer going on. Chris, you want to talk about what this offer is? And
wait a second. Really?
Surprise. Surprise.
Wow.
Yeah.
So for what I paid for mine or no? No? Okay. Just checking.
It's actually better than what you paid for yours. Yeah.
Oh, thanks a lot.
You're welcome. So through the end of September, starting tomorrow, we do have another webinar next month, September 24th, I believe is the day. But we're doing an exclusive offer for anybody that has attended a webinar today, next month, or in the past. If you're not familiar, all the webinars are recorded. They're all online. You can see from 2 years ago, year and a half ago, if you want. But anybody that has attended a webinar and is still kind of on the fence about pulling the trigger and getting a unit, we are offering discounts. It's $500 off the unit. And if you can go back one slide.
That's very generous.
It's better than the 3-unit pricing.
Oh.
It is the most aggressive discount we have ever offered since NuSmile has launched these devices about 2 years ago. So super, super aggressive, huge discounts. Nothing else changes. You're still going to get everything in the picture there. Comes with needles, comes with containers. But that is a very, very generous offer that we are launching starting tomorrow.
And it says you got to call in. I see it on this slide. It says you got to call in to get it.
Yeah, so definitely call us. It's not going to be available online. You can call our customer service team at the number on the screen, or you can contact me, Jordan, or Aaron. We will be sharing our contact info as well at the end.
All right. And then this is just the price of, what we're talking about to buy these needles. If you're worried about the needles breaking your bank, they're not going to. A standard needle is about 11 cents. These needles are about 17 cents. So everybody calm down. Buy some needles. And then talking about money, this is not a barrier to entry. These are very reasonably priced. I mean, like Josh said, go buy some of your other things off of Temu or Alibaba, but this is something that you want to spend. You want to get it right the first time, and you want to get these units that are proprietary to NuSmile. Some tips I can tell you are to be patient and practice. If you constantly default to your traditional syringe, you're never going to get on board with this. You've got to have your assistants pack them up and put them away. It's like putting a lock on the liquor cabinet. We cannot have traditional syringes anymore. We're going to be practicing and being very patient while we learn how to use these.
And where would you recommend a certain type of appointment?
The best appointment is the sleeping appointment. If you can practice on IV sedation day, or if you're doing GA cases, I also would be practicing on 4-year-olds. I wouldn't be practicing on 12-year-old linebackers. I would be, picking, patient selection is key as you're trying to build your confidence. This is a great group. This is a Facebook group that we have. We all live in here. Funny stuff, fun stuff, educational stuff. no shade thrown around. We learn a lot. I go in there all the time just to see like, okay, is there something else that someone's having problems with that I don't know about? So it's a great group. Even if you don't have a unit, I'd encourage you to get on there and snoop around and see what you can learn. And then like Chris mentioned, we've got tons of training available for you. This is Chris, who's on the call here with us. Nice pocket square, Chris. We've got Jordan as well, a great trainer and helper. They just want to see you be successful. They want to see you help your patients. And then, of course, Aaron. Aaron and I road tripped across Texas earlier this year. Wouldn't have been a trip without a stop at Buc-ee's. So please do reach out to all of them. They're all super helpful. And then the training, there's just tons of training available. When they came and trained us here, I asked if they would train every pediatric dentist in Greenville, and they did. We had a stab lab, and they trained all of us how to use the devices. And these are just opportunities. The best way to learn is hands-on, and NuSmile they make sure they get into residency programs. They are at conferences. They've got bourbon and baby teeth coming up. They're going to be at Pearls again next year. So lots of opportunities, AAPD annual session, lots of opportunities to use the devices, touch the devices, where some vendors are, closing up and not going to trade shows. NuSmile is on the trail, making sure these devices, we get to have some tell show do with these devices.
If you are, just one quick thing, if you're a program director or you teach at a pedo program, please let us know. I know a couple weeks ago, I got up at 6 o'clock in the morning or 5:30 and did University of Denver and spoke to their residents. And that's volunteer, right? We do this stuff, Ann and I do this because we're passionate about it and we want to increase education. So if you're part of a program, please reach out to anyone from the NuSmile team or Ann and I, and we can usually figure out some time to talk to your residents. If you have, a program and we get enough residents there, we may be able to get someone from NuSmile to come out and do some live demo. But I know for a fact we can get you connected with doing some online stuff as well. So please let us know.
All right, some final pointers here. When you know the solutions to all your problems but you just don't want to do them, this will solve so many of your problems. I'm also talking to the people on this call that I know are on this call that have the units and they're sitting in a box in the closet at the office. I'm looking at you. I know who you are. This is going to solve so many problems in your practice. The other thing, do not overthink this. You did not have time to overthink it when you were in dental school and stab lab. They threw you in a room with a classmate and you had to do it. You've got years of experience. This should be an easy transition for you to make overall. And don't reinvent the wheel. There are so many of us out there using these devices now. Like when I first got my unit, I didn't have anybody to call. I was calling people across the pond who had it in other countries.
It was Ann.
Yeah. So there are so many people here now and so many videos. And so, you don't have to reinvent the wheel. We're going to make sure that you are confident and ready to help your patients. One of the biggest things we can ask of you is don't just say, it's not working, or it did this, or they're not numb. A video is so helpful for us to help coach you and give you feedback. So if you know you're struggling, please have your assistant take a video and shoot it to one of us or shoot it to someone at NuSmile. That's a really great way for us to take a deeper dive into what your issues are. And so many times when I've looked at a video, I'm right away like, oh, I know exactly what this is. This is like just one tiny shift in what you're doing, and you're going to be, knocking 100 on everybody. All right, we're going to roll through this.
And if you want to talk about scanners, call me.
And if you want to talk about scanners, call Josh.
Okay.
If you want to talk about anything NuSmile, reach out to any of these people on this call. We are completely approachable, completely here to help you. Down in this bottom row right here, Dr. Megan Sharowski is my business partner, dark hair, and she is going to be teaching the webinar with Josh next month, actually. So if you're sick of hearing my voice, you probably won't be sick of her. She's great, and she'll be leading from the front next month. these are the courses we have coming up, restore courses, lots of great hands-on with these devices, as well as the scanner, as well as, dentistry in general. We've got one coming up this weekend in LA. Then we've got Megan's teaching that one. Josh is teaching in Newburgh. I'm teaching in Fort Lauderdale. So if you don't want to see us, pick a different course. And we just want to say thank you guys so much for hanging in here tonight. And just, learning something new, getting out there, learning something new.
Are there spaces open in Newburgh? Or is that sold out?
Yes, we are.
So
LA
please,
is sold out for this weekend, but Newburgh, we have a few spots left.
if you're thinking about it, and there's nothing better than jumping in hands-on. I'm helping on Saturday, but I'm teaching on Sunday. So I will be completely free on Saturday. So if you want to come talk about these devices, you want to talk about scanners, you want to talk about restorative, you want to talk about practice management, I'm there to work. So please reach out to me directly if you're going to be there, plan on coming, and my time is yours.
Well, I will be in Fort Lauderdale and I am there to play. I'm going out 2 days early.
Yeah,
so if anybody
right.
wants to come play in Fort Lauderdale before we teach, that's where you'll find me. And this is how you can find me and Josh if you don't know that already. These are our contact codes. And then I'm going to turn it over to the NuSmile team so they can continue to talk about, answer any questions or anything that's popped up in the chat or anything you want to end with here.
Awesome. Thank you so much, Ann.
Absolutely.
So first question tonight, does the local anesthetic have any effects for the developing permanent teeth if you inject into or proximal to the follicle?
Great question. So we're using a 9mm needle. If you get anywhere close to a permanent tooth with a 9mm needle, we got to have a conversation about how you're using these. So you think about with a 9mm needle, you're still leaving about 2 to 3 millimeters outside of bone. You are not going to have an issue with coming close to touching a permanent tooth. Hypothetically, let's say that permanent tooth is sitting right on the opposite side of the plate. This is manual bone penetration. We're not drilling these in like it with an X-tip. So you've got to have He-Man or He-Woman strength to be able to push that manual bone penetration into a formed permanent tooth. These units will keep you safe as far as pressure goes. So you can feel safe knowing that if it senses that there's too much, if anything, they're too conservative, which is fine. I mean, I would love for sometimes if it wasn't as conservative, but that keeps us safe. It will shut that unit down if it senses, that algorithm is reading, I think sometimes up to 1,000 times a minute. It will not let you overpressurize the system.
And I also think a lot of us have PTSD from some dental school instructor who convinced us that we're going to ruin permanent tooth follicles. I don't want to be nonchalant or flippant about it, but I want to, whoever asked that question, I want you to take that fear off the table. Don't be afraid of it for the reasons Josh said.
I think another important concept is we think we are, as advanced we are in the United States, we are one of the last countries to get these units. So they were first started, it was 15, 16 years ago now in France and Europe. And we are one of the very last to get these. So they have been used worldwide until NuSmile plunked down on you want to know how much money and time into FDA clearance to get these units to us.
Awesome. And let's see here. The next question is going to be, I have a number of patients who struggle isolate tongue retraction because the tissue isn't numb. Strong gag, tears from touching the tongue, etc. How to manage these patients? There's
this cool thing. It's called a rubber dam. And you put this clamp on. I'm being a little flippant. I'm a big rubber dam fan, even though I do like the isolate. My personal feeling is if they're having that much difficulty, gagging with an isolate, you should be using a rubber dam for them. And if you're not used to using a rubber dam, give me a call. I will give you more information than you ever want to know about using a rubber dam. And I'm sure you have comment there too.
I really don't. I mean, I think we all struggle with gaggers. I mean, those are the kids you're scheduling at 8 o'clock. You've got them NPO. You've got them wiggling their toes. We've bought those little stickers you can put on their chin. That's like an acupressure thing. I mean, I wish there was a hooey way that would fix all of this, but gaggers are tough. Yeah, you can't put an isolite in a gagger sometimes.
And if you need to, I guess hypothetically, you could use a little topical in the lingual vestibule to get a little bit of local anesthetic effect for your isolate if you need to.
They're going to gag with that too.
They're going to gag with that too. Correct.
I'm gagging thinking about it.
So we have one last question here. So please, if you have any questions, be sure to ask away before we go ahead and answer this. So if you have any questions, put them in the Q&A. But this question is, this may have been mentioned, if I access from the buccal, will the lingual tissue be numb?
Yes. That's the glorious part about it. Especially if you love a rubber dam, you put that clamp on right away and that lingual tissue is numb. If you're doing an extraction, you can pick up your elevator and elevate all the way around, circumferentially around the tooth, and it's numb. So short answer, yes. That is a glorious feature of these devices of delivering intraosseous anesthetic is everything around that tooth is numb.
Just as a technique thing, I find, let's say I'm in a clamp 30 and I want to make sure that I'm restoring S&T. I'll tend to probably go to more of a half carp than a quarter carp if I want to make sure I'm getting profound local anesthetic on the lingual of 30 as well. If I'm using an isolite, I tend to use a little bit less. So some of that also is volume dependent. And if you're using just enough local to get the teeth numb, you may not have adequate anesthesia on the lingual. But if that's the case, you're just going to, make sure. I think safe-wise, give a half a carp if you're going to use a rubber dam in that quadrant. And do you find that's the same, or with a quarter, you're fine with a rubber dam? Let's say on a 5-year-old.
I don't use a rubber dam.
Okay, there you go.
Awesome. Well, we don't have any questions at the moment. So if you have any last minute questions, please put them in here. But in the meantime, while we're wrapping up, again, please check for CE coming from Zoe, Nicole, or Coral. That'll be coming tomorrow or Friday. Fill that
I'm
out.
just a little annoyed that the deal that you have now is so good. Thanks a lot, guys.
I would just like
more
to
units.
I'd just like to say Bourbon and Baby Teeth is coming up, and we've got a lot of other meetings coming up. And if you see me, and I think I speak for Josh or any of us that you've seen on the slides, Aaron, and you recognize any of us, please walk up to us. Please say, oh my God, I want to know more, or I love it, or I'm having a problem, or pound sand, or let's have a drink in the bar, whatever you want to say. But don't, this is like become family for us, and we want to get to know you better. So please make sure that we're not on some like high pedestal. I mean, you're sitting in your living room in your pajamas, and I'm sitting in my living room, not in my pajamas, but I'm going to get in them shortly. So, we want to make this NuSmile is there, a family run business. And that is one of the reasons we love being involved with them.
Really quick, that question about hypoplastic first molars, this is your saving grace. I treat a lot of hypoplastic first molars a lot of them in my practice. And I would struggle with a standard injection with a block trying to get those teeth numb. And, one of the studies we show, I think it's 80% or more where hypoplastic molars get profound local anesthetic. In my hands, I would say it's almost 100%. It has been the godsend for me on treating those teeth because, as you know, they can be very difficult with a standard block to get numb. Just do not have that problem anymore. Just not a thing anymore.